I think we'll go ahead and get started. Good morning, everyone. Welcome. My name is Kelly Bauer. I am an assistant professor at the Johns Hopkins School of Nursing, and I am the MDMOM Hospital Initiative project lead. On behalf of myself and my hospital initiative colleagues, Nicole Warren, Brianna Kramer, and Bonnie DiPietro, as well as the entire MDMOM team, I want to say how excited we are to have you here with us this morning to share with you the details of this initiative. So really, we're so pleased to have had 27 of the 32 birth hospitals in Maryland registered for today's webinar. Unfortunately, we're too big a group to have individual introductions. So instead, we'll ask that you please take a moment to type your name, type your hospital's name and the county where your hospital is located into the chat box so that we can all see who's here and we can welcome one another to today's webinar. And as I give folks a moment to do that, I also want to invite you to, throughout the webinar, to chat any questions that you have into the Q&A box. So we won't be using the chat function for questions. We'll be using the Q&A box for questions, and that can be found on the bottom right-hand side of the toolbar that comes up on the bottom of your screen. Feel free to enter those questions at any point during the webinar, but we will wait until the end to answer those. Great, so great to see so many people here. Welcome to everyone. Thank you for introducing yourself in the chat. It's just really wonderful to see so many folks really from all over the state. So again, once again, welcome. Thank you for being here. So next we have another really important welcome. At this time, I'd like to introduce Maryland delegate, the Honorable Jocelyn Pena-Melnick, to make some opening remarks. MDMOM's collaboration with the delegate Pena-Melnick is a really powerful example of how policy and practice can work together to advance maternal health. Welcome, delegate.
Thank you and good morning. I want to take a minute to thank and welcome all of you that you made the time to be with us this morning because this is such an important topic. You know, the data speaks for itself and it looks pretty bad for Black women. MDMOM, thank you for your work. Thank you for your collaboration on House Bill 837. I couldn't have done it without you because you gave it validity and people trust your work and your judgment. I put in this bill because I wanted to make a difference, because the data, when I saw how Black women are dying almost 4 times the rate higher than white women, it broke my heart. At a time when you're having a baby and you're happy, I know because I have 3, I have a boy and a set of twin girls, and you are just excited about it. You know, you don't think that you're going to die. It's never in your mind. You're nervous about it. And you think you're getting the best care, but the fact is that not everybody's getting the same care. And that we have, you know, a lot of disparities in healthcare. And your work is helping reduce those disparities. And I am grateful for that. And I'm grateful for all the hospitals that are here today. House Bill 837 requires implicit bias training for those providers that touch a pregnant woman, in plain and simple, in plain English. So here you have a course that has been developed, not just on implicit bias, but 3 other trainings as well. And I know it's voluntary, but I really hope that you take advantage and do it because you will be making a difference. I'm not going to take your time anymore. You're here to learn from the best. And I thank you for your time and for your consideration, and have a wonderful, wonderful day.
Thank you again so much, Delegate Pena-Melnick, for being here this morning, for taking the time, and for your continued support of our initiative. We look forward to continued collaboration with you and your colleagues in the Maryland General Assembly as we continue to work towards reducing maternal health disparities in Maryland. Thank you.
Thank you.
Okay, and here's a quick look at our agenda for today. We are going to start with a broad overview of the MDMOM program, and then we will provide some specific details about our hospital initiative. We are particularly excited to have with us today the experts that MDMOM has partnered with to develop the trainings that we'll be offering. Ms. Mallory Empare and Ms. Ronnie Jenkins are here from March of Dimes, as well as Dr. Callahan and Dr. Turplin. Each of them is an expert in their field, and we're so grateful for their contributions to this program. Then we'll wrap up at the end by sharing a little bit about our evaluation plans, program incentives, hospital commitment, what comes next, and then of course at the end we should have plenty of time to answer your questions. And now I'm very pleased to introduce Dr. Andrea Kriagna, Associate Professor at the Johns Hopkins School of Public Health and the MDMOM Program Director. She'll provide us with an overview of the MDMOM program. Andrea?
Good morning, everyone. Thank you so much, Kelly. Welcome to today's webinar, introducing the MDMOM Hospital Initiative. We are very, very grateful for your participation, especially in light of the COVID-19 pandemic. We are mindful of the extraordinary burden this pandemic has added to hospitals and every one of you as frontline health providers during this pandemic. As some of you already know, the MDMOM program is a 5-year program that started in September 2019 and aims to improve mental health in Maryland. The program is a close collaboration between the Johns Hopkins University, the Maryland Department of Health, the Maryland Patient Safety Center, and the University of Maryland, Baltimore County. We are funded by the Health Resources and Services Administration. It's coordinated closely with the newly established Maryland Maternal Health Task Force. The MDMOM program has 2 specific objectives. One is to improve maternal health data availability and utilization, and the second is to innovate in maternal health service delivery. For the first objective, we are developing and started already to disseminate data briefs and publications highlighting trends in maternal health in the state. We have established a pilot severe maternal morbidity surveillance and review system, working currently with 6 of our 32 birthing hospitals in the state, and aiming to scale up the program and include more hospitals starting next summer. We are developing a Maryland Maternal Health Data and Learning Center with 3 different functions: maternal health data dashboard, data entry system for severe maternal morbidity surveillance, and a learning management platform that Kelly will talk more about. For the second objective, focused on innovations in service delivery, we have the Hospital Initiative, which includes trainings and equity-focused interventions that you will hear about today. We also have an ambitious plan to coordinate a perinatal telemedicine network in the state to specifically benefit the 17 level 1 and level 2 birthing hospitals in the state, as well as work plan with the more than 50 home visiting programs in Maryland to improve postpartum warning signs education for women. And of course, the MDMOM program presents a valuable opportunity to evaluate these efforts and inform programming and resource allocation for maternal health in Maryland in the future. But today we are going to focus on the components highlighted here, which constitute the MDMOM Hospital Initiative. To put this initiative in context, I want to highlight some key data. Shown on this graph are maternal mortality data between 2010 and 2017. Notably, pregnancy-associated mortality was highest in 2017, year when 52 women died during pregnancy and the 1-year postpartum period. And of the 52 women, 20 of the deaths, or 39%, were due to unintentional drug overdoses. Now, the good news is that results from an in-depth analysis of the most recent 5 years of maternal mortality data from Maryland that we currently have on our website and we shared with all the birthing hospitals in the state already, these data show that 81%, or 4 in 5, of all pregnancy-associated deaths in Maryland were preventable or potentially preventable. As depicted on this graph here, striking racial ethnic disparities exist in both severe maternal morbidity and mortality in our state. And therefore, the MDMOM Hospital Initiative is designed to address these disparities over the next 4 years. With that, I'm gonna pass it back to Kelly and let her introduce the Hospital Initiative and everything that we have planned for our hospitals. Thank you so much.
Great, thanks so much, Andrea. I think it's so helpful to frame the Hospital Initiative in this broader context of maternal health in Maryland, as well as the other MDMOM program components. So now I'd like to provide you with more detail about the Hospital Initiative. The goal of the initiative is to promote equity and safety in Maryland birthing hospitals, and we propose 2 approaches to this. First, by offering staff training to facilitate learning from adverse maternal events from here in Maryland, as well as recognition of the impact of bias on patient care. Secondly, the initiative will support quality improvement leaders to carry out interventions that promote equity and safety initiatives by using the Maternal Health Equity and Safety Toolkit, which is being developed by the MDMOM team. Put simply, the Hospital Initiative includes 3 core offerings for hospitals: online trainings, skill building sessions to expand on the learning from online trainings, and access to a maternal health equity and safety toolkit. These 3 offerings are intended to be complementary and to build on one another. All this starts with online trainings, which will become available starting in and continuing through 2021. These trainings will be asynchronous sessions offered to frontline providers who are working in labor and delivery or postpartum units. They can complete these trainings online on their own, and they will be available through the mdmom.org website and a learning management platform that we have developed. There are 3 online training topics. The first training will become available is a 1-hour training called Breaking Through Implicit Bias in Maternal Health Care, which was co-developed by March of Dimes and Quality Interactions. This training will meet the implicit bias training mandate from the Maryland House Bill 837 and will be available to Cohort 1 hospitals starting in March and Cohort 2 hospitals starting in June of 2021. Second will be a 1-hour online training called Learning from Adverse Maternal Outcomes in Maryland, which is focused on severe maternal morbidities using case studies of adverse events that have happened right here in Maryland hospitals. This training will be available to Cohort 1 hospitals starting in June and Cohort 2 hospitals in September of 2021. The third online training that we'll offer is a 1-hour online training called Managing Bias in the Care of Patients with Substance Use Disorder. This will be available for Cohort 1 hospitals starting in September and Cohort 2 hospitals in December of 2021. Each of these online trainings will be followed by 2 skill building sessions. These will be either virtual or face-to-face if conditions permit, but they will use a synchronous group learning approach and will be offered to the staff on your unit. These sessions are designed to reinforce the content from the online trainings and to build competencies that can immediately be put into practice. Skill building sessions will be scheduled at times that are convenient for you and your unit. For instance, perhaps that's during a weekly meeting or on a simulation training day. I mentioned earlier in the webinar that MDMOM has partnered with national experts to develop and offer this content and your hospitals, to you and your hospitals. And we are just so pleased to have these experts here with us today to give you an initial sense of why these topics matter, what you can expect in the trainings, and how the content will impact practice. We're going to start by introducing our first training, which will be offered, which is Breaking Through Implicit Bias in Maternal Health Care. I'm pleased to introduce our first 2 experts who are here from the March of Dimes, Ms. Mallory Empare, who is Director of Maternal Child Health at March of Dimes, and Ronnie Jenkins, who's Director of Implicit Bias, both of whom are experts in maternal health equity, and we're so fortunate to have them here with us today. Mallory and Ronnie, welcome.
Thank you, Kelly, and good morning, everyone. We're really appreciative to be here today to share a little bit more about our training. I would like to first sort of give some context and understanding of where this fits into March of Dimes' sort of larger strategy. So as an introduction for you all, I'm sure many of you are familiar with the March of Dimes, but just to do a little bit of level setting, we are a national nonprofit and we work to improve health outcomes for all moms and babies. And for us, next slide, please. That means ending preventable maternal risks and death and ending preventable preterm birth and infant death. So in terms of our strategy, we really see ending the health equity gap on both of those sort of larger measures as the surest way to see lasting change towards those 2 lofty goals. So this is sort of where our implicit bias training sits. It's really an effort, a jumpstart conversation with our provider partners, whatever their role might be in terms of providing maternity care, maternal care, whatever their towards that end. So I'm going to go ahead and turn it over to Ronnie, who's going to briefly share a bit about our training and give you some details about the key learnings that you can expect to receive based on the training. Ronnie.
Great, thank you, Mallory. So hello, everyone. I'm so happy to join you all today. As they stated, I will be the lead trainer on this project, and so I will be a great point of contact in case you guys have any questions throughout your training process. Next slide, please. And so the American Hospital Association recognizes the value of this important training program and the potential benefits of its use by healthcare providers across the country to better identify and remedy implicit bias. And so, as Kelly stated earlier, this was developed in partnership with Quality Interactions, and this training is geared towards building awareness and foundational knowledge around implicit biases and structural racism. And so the US is facing a maternal and infant health crisis, as many of us know, and it's among the most dangerous developed nations for pregnant women, new moms, and babies. And so one potential threat is implicit bias. And so these attitudes and stereotypes that affect an individual's understanding, actions, and decisions in an unconscious manner. And so our training provides a unique virtual learning experience for you all that provides authentic and compelling content about caring for women before, during, and after pregnancy. And so training alone won't lead to immediate improvements in racial and ethnic disparities, but it can provide healthcare providers with important insights to recognize and remedy implicit bias. And so these actions can result in improved patient-provider communication, overall patient experience and quality of care, and a culture shift across committed organizations towards the broader goal of achieving equity from all moms and babies. And so I just want to give you guys a quick insight as far as what this training content entails. And so our training's learning outcomes include explaining implicit bias, including its cognitive basis and potential impact on maternal care. We describe how structural racism in the United States contributes to implicit bias. And then we begin to understand how to actually mitigate that bias using strategies such as the ally model. And then participants are engaged by addressing how to apply an equity lens to their day-to-day. And so in regards to the different modules that the participants will experience, first and foremost, we go over an overview of implicit bias. And so this section introduces racial and ethnic disparities, pregnancy-related mortality data. And so it explains the social cognitive process that underlies implicit bias and includes an explanation of stereotyping and stigma. And so stereotypes, as we know, are the mental shortcuts that contribute to this biased thinking. And so it includes or concludes with a discussion on healthcare provider experiences with implicit biases and stereotyping, and actually provides real life scenarios for our participants to engage with. Next, we go into structural racism in the United States. And this is going to be a very key component in this to really establish not only the definitions of race and racism, but it also discusses how racism operates on 3 levels in society. So it differentiates between structural and institutional racism, which is related to why a structural lens is required to address racism, and how this is related to implicit bias. And so this section offers a history of structural racism, including examples in research, medicine, healthcare, and maternity care. And so the weathering phenomenon helps explain how racism can directly influence the patient and group health outcomes. And then there also is a discussion piece of the consequences of institutional racism in maternal health care and that they experience, including the highlights of enduring legacy across society and more. And so part 3 is really that important aspect of learning how to mitigate that implicit bias using different strategies. And one in particular we like to highlight is the ally model, which offers 4 simple strategies to address personal implicit bias. And so this is a tool that participants can actually walk away with. And so they learn to avoid assumptions by relying on objective information and evidence. They learn about the whole patient by asking open-ended questions, listening more than they talk, and yielding to the patient by involving them in their care. So really having that shared decision-making process, which relates well coupled with the AIM bundles. And so these strategies are based on principles of motivational interviewing techniques, patient teach back, and other communication strategies. And the last one is really committing to creating a culture of equity. And so this section really provides a call to action to prompt applying learning to efforts to impart organizational change. And so the organizational leadership strategies, workforce development supports, and business case examples are included. And again, they are provided another tool for the Keep, Stop, Start to really create an individual action plan to contribute to the larger picture.
Wonderful. Thank you so much, Ms. Impare and Ms. Jenkins, for being here today. We are so excited to be able to offer this training to our Maryland hospitals and to build on this training through our skill building sessions and through the Maternal Health Equity Toolkit. Thank you. Now we'll be hearing from our second expert, Dr. William Callahan, who has worked with the MDMOM team to develop our second training, which is titled Learning from Adverse Maternal Outcomes in Maryland. Dr. Callahan is an OBGYN and a maternal health epidemiologist. After 14 years in clinical practice, Dr. Callahan earned his NPH and joined the CDC, where he worked for 18 years and where he ultimately served as the branch chief of the Maternal and Infant Health Branch in the Division of Reproductive Health. He's a highly respected national authority on maternal health, and we're so fortunate to be working with him and to have him here today. Welcome, Dr. Callahan.
Thank you and good morning. I'm thrilled to be part of an effort like this that is so comprehensive in its scope and is really, I think, will be a national example about how we can do statewide quality improvement. So I was charged with developing training modules for looking at maternal mortality and severe complications of pregnancy, what we usually refer to as severe maternal morbidity. And the first part of that would be to kind of provide the big picture overview of what's going on in the country and the state of Maryland with regard to maternal deaths and severe morbidity. And so what the initial part of this training is going to do is essentially look at trends, look at causes of death, and will again, and I think everybody that is going to be involved in this we've heard from previous speakers, certainly have an emphasis on equity, because we know that the risks are not spread equally across all women. The biggest part of what I did was to look at cases from Maryland. So there were cases of maternal death and cases of severe maternal morbidity that had been reviewed in Maryland. And I looked at what was sent to me, and in consultation, we selected 3 cases of maternal mortality and 3 cases of severe maternal morbidity, and provided case summaries. Next slide, I think. It's coming in. The training will provide vignettes of these cases. We looked at the case summaries, gleaned all of the information that was available, and provide a narrative story, if you will, of what happened during the prenatal and perinatal time period for these women. So we provide a case summary, and in many ways it's sort of built on the model of the traditional history and physical, where we provide a description of what the woman's history was, what happened during the course of her hospitalizations, if that's pertinent. We looked at social history, family history, all the sorts of things that we would kind of use to describe what happened. And then at the end, we kind of try to provide a summary. So these are the key events that we've identified. We try to at least look at this from a lens that were there opportunities here where if things went differently, if an intervention occurred or if an intervention didn't occur, would we have had an opportunity to alter that outcome? And then develop learning things. So the reason this is all done from a perspective that this is how quality improvement happens. It has to happen. If we just count maternal deaths and say we had 3 deaths from cause A and 7 deaths from cause B and so on, there's no way to use that information just in its on surface to institute systematic changes in how women are cared for. So even though it may appear that a case is presented as anecdote, that anecdote can provide lots and lots of clues, almost always, that will inform what needs to be done systematically to improve quality of care. And as you can see, there's an application pending. This will be qualified for CME as well. It's been a very enlightening experience to go through all of this, and I'm hopeful that participants in the training will come away with some real enlightenment about how the process of case review of adverse events can inform improvement in quality of care. Thanks.
Thank you so much, Dr. Callahan. It's really exciting to be able to offer our hospital partners learning that's local, the local cases, the cases that have happened in Maryland. It's really exciting and important, so thank you. And finally, we invite Dr. Mishka Turplin to share more with us about the 3rd training, which he is developing. It's titled Managing Bias in the Care of Patients with Substance Use Disorder. Dr. Turplin is board certified in both OBGYN and addiction medicine. He previously served as the medical director for Behavioral Health Systems Baltimore, and he authored the ACOG Joint Committee Opinion, Opioid Abuse, Dependence, and Addiction in Pregnancy. Currently, Dr. Turplin is the Associate Medical Director at Friends Research Institute. He's a substance use warm line clinician at the National Clinical Consultation Center at UCSF, and he's a Deputy Chief Clinical Officer at the Department of Behavioral Health in Washington, D.C. He is a highly sought after national expert, and we're so fortunate to be working with him. Dr. Turplin, thank you for being here today. Welcome.
Thank you. Thank you. This is really an exciting initiative. I so appreciate being part of this and everyone's who's here on the call. And you guys, you can go to the next slide. And in particular, like how this is, grounded in equity. So what I'm going to sketch out real briefly are really the principles, behind the curtain of the training that I'm developing. And then some strategies briefly. So really this centers on the most vulnerable. And what I mean by that is, to look at the systems of care for people who are pregnant, who have opioid or other substance use disorder from the perspective of somebody with that. What systems does she encounter? What people does she encounter? What is her experience in that? So the next slide. So really when we're talking about this, we're seeing what people experience is stigma, bias, prejudice, and discrimination. And these are some data. Almost 50% of nurses who care for infants with neonatal abstinence syndrome endorse feeling angry towards women who use drugs while pregnant. 40% of medical students and trainees, residents, think that mothers who use drugs during pregnancy should not be allowed to retain custody of their kids. And 40% of these are trainees and residents blame the mother of an infant with NAS for the infant's health problems. So next slide. So what we're talking about is really this sort of the intersectionalities of different stigmas. gender, reproduction, race, addiction, and etc. And what emerges, from this are really these narratives of deserving versus undeserving motherhood. And you can see this was an article about a woman who had a use disorder, who was trying to regain custody of her kids. And these are the the comments in the New York Times. Using H while pregnant, it is the deal breaker. Sure, the parents love the child, but do they love him more than heroin? It comes down to one or the other. I have no sympathy for her. You use drugs while pregnant. You do not care about the child. And, some people should not be allowed to have children. So this is taking place in the context of policy changes that, unlike general drug policy, which is bending away from the punitive, drug policy related to substance use, to pregnancy in particular, is becoming more punitive across the United States. There's an increase in punitive state statutes in this context. So, in putting together this training, we're going to, it's going to touch on, centers on the most vulnerable, relates to policy, but also on the ground are the strategies and what we can do. And what this, means really, like walking through how we, center on empathy, operationalizing what empathy is. And one of the great ways of doing that, March of Dimes, was laid out very, very nicely, is using sort of the ally model. So thank you. I look forward to the questions and conversation and to working with all of you in the near future.
Fantastic. Thank you so much, Dr. Turpin. It's really exciting to hear your passion, and we're looking forward to offering this training to our Maryland hospitals and to also building on this training as we look to the Equity and Safety Toolkit and thinking about policies and practices to really support quality care for our patients who are using substances. Again, a big thanks to all of our experts for being here today. It's so exciting to hear directly from each of you about what our hospitals can look forward to in your trainings. And now I will briefly introduce the final offering of the MDMOM Hospital Initiative, which is really designed, like I've said, to build on these trainings and skill building sessions. The Maternal Health Equity and Safety Toolkit. Now, this is still a little while off, but we do want you to know that it's coming. In fall of 2022, after all the trainings and skill building sessions have been made available, we will introduce the toolkit. Our provider trainings are really a first step towards building a culture of equity and safety, and the toolkit will offer a menu of options to support and expand on this culture change. It will include strategies to support the use of data for accountability, for updating policies and practices, and for improving communications and continuity of care. MDMOM team members will support hospitals to implement interventions from the toolkit over the course of about a year. We'll meet with quality improvement leaders regularly and provide technical support and assistance. Now, we have spoken to many of you already in our formative work in developing all of this, and we know that many of your hospitals are already engaged in a variety of innovative strategies for the promotion of equity and safety. And so it's important to know that the toolkit will be easily customizable for your institution so that you can build on your unit's unique strengths and address your specific needs. And so that's the broad overview of the MDMOM Hospital Initiative and our offerings. The online trainings will become available across 2021. The skill building sessions will be scheduled at your convenience in 2021 and 2022. And the Maternal Health Equity and Safety Toolkit will be launched in 2022 and through 2023. Hopefully you're wondering how we plan to evaluate the impact of these efforts, and I do want to just touch very briefly on our evaluation plan, because both HRSA and the MDMOM team are really committed to conducting rigorous evaluation of this initiative so that we can be responsive to hospital needs, so that we can make mid-course corrections, measure the impact of these initiatives, and help direct future investments designed to reduce disparities both in Maryland and beyond. Our evaluation plan includes data collection at 3 time points, which you'll see here. We'll distribute 3 surveys to hospital staff over the course of about 3 years, starting with our baseline survey that will be in early 2021. Any of your labor and delivery or postpartum staff who complete these surveys will be compensated with a $20 gift card, and our evaluation has been IRB approved. In an effort to describe how we plan to accomplish all of this, we'd like to also describe how we hope to partner with each of the 32 hospitals in Maryland. First off, our goal is to work with each of you and your hospital to be as supportive and flexible, and to make it as easy as possible for you to roll out each of these offerings to your unit. We're also able to offer a few incentives for our participating hospitals. First, we'll be able to track and report back to you your staff participation in these online trainings. There are, as you've heard, CME and CNE credits available for the online implicit bias training, and we are in the process of applying for CMEs and CNEs for the other 2 online trainings. I also mentioned already that your unit staff who choose to complete the baseline, midline, and endline surveys will receive a $20 gift card for each survey. And finally, we will provide sponsored staff parties as well as banners for your hospital, recognition on our MDMOM website, all to acknowledge your participation achievements. Just briefly, if you haven't seen it already, I'll show you quickly the mdmom.org website where we will be highlighting some of these achievements. If you look at the top of our webpage under resources, you'll see a birthing hospitals option in the drop-down menu. And there you'll find this interactive map of all of the Maryland birth hospitals. Then if you click on a particular hospital, there's a brief profile like the one that you see here. And this is where we'll be adding information to recognize your hospital's participation in these trainings and offerings. And now, what are we asking from you and your hospitals? As I've said, we sincerely hope that participating in the MDMOM Hospital Initiative will be pretty simple for you. First, we have already sent you an email in November. You should have received an email asking you to identify at least 1 physician and 1 nurse champion. We also encourage a midwife, a nurse practitioner, and a physician assistant champion if those are roles that you have in your facility. Experience tells us that one of the most effective ways to engage staff in programs like ours is to have a respected colleague who will encourage participation. And so, for instance, they might mention it during a morning huddle or at a monthly department meeting and so forth. Second, we'll be asking you to disseminate the MDMOM evaluation survey by email to our labor and delivery and postpartum staff, to your labor and delivery and postpartum staff. This would include reminder emails and possibly some verbal reminders in staff meetings or other encounters. But we will be sure to provide you with all of the email communication language so that all you need to do is click send. And next, we'll ask hospitals to participate in, at most, a monthly call with an MDMOM team member, just so that we can do a quick check-in and help to troubleshoot anything, any needs that have come up or things that we can help with. In order for us to track staff participation in these trainings, you will need to provide us with a list of your staff. And of course, we'll ask you to help promote the trainings by informing and encouraging your staff to participate. And then finally, when we release the Maternal Health Equity and Safety Toolkit, we will be asking hospitals to look at their data, their unit data by race and ethnicity. Now, we know some hospitals are already doing this, but we also know that some are not. And so we share this with you now, well before the toolkit becomes available in 2022, so that if you need, you have some time to work with your IT team to get this on their radar and start putting in place what you need to make that possible. And so what's next? Well, first is selecting your cohort. As a reminder, cohort 1 hospitals will distribute baseline surveys in January or February, and the implicit bias training will become available to them in March. Cohort 2 hospitals will distribute the baseline surveys in March or April, and the implicit bias online training will become available in June. 10 of you have already completed the cohort request, so thank you. If you haven't responded, please do so by this Friday, December 11th. We do still have a lot of open slots for cohort 1, so please consider joining sooner rather than later. Next is to identify your champions, which I already talked about, and to get started making a list of your staff who will be participating in these trainings. And then finally, just stay tuned for more communication. Brianna Kramer, Nicole Warren, Bonnie DiPietro, and I will be reaching out to each hospital individually to make brief personal introductions and to just check in and see how we can be helpful. Okay, and now I will stop talking so that you all can ask questions. If you haven't already, please feel free to type your questions into the Q&A chat box or the Q&A box. So again, that's on the bottom toolbar on the right-hand side, not the chat box, but the Q&A box, if you could please. And we will be sure to unmute our guests so that if you have questions about the specific trainings, they are also here and available to answer those. So I do see there were a couple of questions about the slides, and we will be happy to make these slides available after the presentation. And another question here is, will this include emergency department providers? So as it stands right now, we have the capacity to provide trainings to providers and staff that work on labor and delivery and postpartum units. Andrea, I don't know if you want to say more. I think that if we,
Yeah, I think based on you know, requests and recommendations from maybe department chairs, we can probably allow emergency department providers to take the trainings as well. This is information that is you know, going to be highly informative for these providers as well. So I think we should make it available.
Yeah, thank you. Another question is, how long will staff have to complete the trainings? So there isn't a specific period of time. These trainings, once they become available, they will remain available. What we do hope is that they can be completed over the course of maybe 2 or 3 months, and they can be completed prior to us coming to your hospital or meeting with your hospital virtually to provide the skill building sessions, because ideally your staff will have viewed the online trainings prior to those additional skill building sessions, but there is not a certain period of time to complete those trainings. And what about ambulatory sites for the to receive the trainings, Andrea?
I think many of these sites are actually satellite sites to the various hospitals in the state. So the answer there, Susan, would be yes. I know what you're talking about exactly.
Great. Any other questions? And I think maybe Shelley Chu left early, but I think, as you all know, Dr. Shelley Chu from the Maryland Department of Health is a really key partner in the MDMOM program. I was able to come and speak at her meeting in October, and we just have been so grateful for her continued support of this work. I'm happy to have her here today. Can the online training be done from home? Yes. So we are really fortunate to have a wonderful information technologist, that's wrong, information technology scientist from the university, from UMBC, Ganesh Karu, who has developed our website, who is developing a learning management system that can be accessed via our website. So as long as a person has, you know, good Wi-Fi access, it should be no problem for them to complete it from home or from any other location. And that's a case that would be the case for all of our online trainings.
If you don't mind, if I can just kind of add to that, specifically for the Breaking Through Bias training, it is only about an hour long. And you can start and stop and come back to it. So that's the other benefit with that training. So if you are having a hectic schedule, you are able to start and stop, and they'll continue on directly where you left off.
Thank you for that, Ronnie. Yeah, we do. Again, we know that providers who will be taking these trainings are busy, that they have a lot of demands. And so we do want to make it as easy as possible. So hopefully the attributes that Ronnie described will be helpful, and the fact that they can be completed online from home or wherever is convenient will be helpful. Any other questions? And we are not opposed to gifting you back 15 minutes of your day, but we also want to be sure that we've answered any of your questions before we end. Okay, and any other last comments from my MDMOM colleagues or any of our guest speakers today?
If you guys have any questions about our training, please feel free to reach out to me, and I can put my email address in the chat box.
Oh, great. Thank you, Ronnie. That would be great. We are so pleased to be able to be in partnership with the March of Dimes and offering this. And we are happy to stay on after the formal end of the webinar. So if anyone has additional questions they want to ask us sort of in a more informal space, we're happy to stay on. And like I said, you can expect in the next month or so to be hearing from myself, Brianna, Nicole, or Bonnie, just to check in, have a little bit of a one-on-one contact and see if you have questions that we can answer at that point, because we know that questions may continue to come up over the course of this program. So with that, I just want to say again, a huge thank you to all of you for being here. We really value your time and appreciate that you've made the time to be here with us today. We're so excited to be able to offer these initiatives and offerings to your hospitals and to begin working with you in 2021. So that is it. Thank you all for being here. Have a great afternoon.